It's a pleasure to be with you for Congenital Aniridia, and I would like first to thank the organizer of Aniridia Europe conference in London. And also, I would like to thank also Aniridia Europe Association and Generis Association for their support. So I'm very happy to present congenital aniridia genotype-phenotype correlation with my colleagues from France, Paris. So first of all, is it a coloboma or an aniridia? For sure, it's a partial aniridia because this is not the location of a coloboma. So sometimes partial aniridia are really tricky, and it's very important to recognize it and to see what are the implications of it. So congenital aniridia could be a complete aniridia or partial in the left slide, and could be also with other complication like cataract, and we will see the different features we can encounter. So aniridia disease is really a panocular disease model. It means that there is really different problems that can go for the patients. Of course, the most easy way is to just individualize aniridia. And also, this is sometimes ptosis, but also nystagmus that can be the first sign, and photophobia. And in young children, in infants, these all signs must be identified by the practitioner first. And also, of course, the iris hypoplasia or plasia could be complete or incomplete. That's when it's incomplete, when the diagnosis must be sometimes difficult. After that, there is limbal insufficiency by the problem of stem cells deficiency. And it could be very early, we will see, and sometimes that we see the signs in very young children. Glaucoma also is a high risk in aniridia, in congenital aniridia. Cataract also could be congenital cataracts and could be also cataracts in quite juvenile cataracts. We observe also foveal hypoplasia, and it is very important to have imaging to individualize this hypoplasia. And sometimes there is also hypoplasia of the optic nerve. So when you do look the ocular anatomy, we will see that there is really all the eyeball that have a problem with different features like limbal insufficiency, cataract, glaucoma, and foveal hypoplasia. And all of these must be integrated in the disease. So in aniridia, variable phenotype can be observed. Just look at this mother. She was just individualized as a simple coloboma, and she didn't know why the vision was so low. And that's why it's very important, because she has no idea that could be the risk for their children. And the daughter has a complete phenotype with a complete aniridia and also more severe problems for the observation of the aniridia and complications. So we know that it's most of them is 90% is PAX6 mutation or deletion, and we can see that could be also with deletion affecting WT1 for Wilms-Tumor. We will see that with syndromic aniridia. We know also that ocular embryology of PAX6 gene explains what we see, what we observe, and there is many observation that has been very useful to understand the disease. We must know also that aniridia, congenital aniridia, could be also involved with the diabetes, because there is PAX6 expression in pancreas, and we can see early diabetes type 2 and in aniridic patients. And so glycemia checkup regularly should be done, and it's very, very important to know that. We have in Necker a patients cohort of 342 patients registered in our database in Oftara Center, which is rare eye disease center accredited by the ministry, the French health ministry, and it's just organized with the Filière Sans-Gêne. We are also member of ERNI, also a network in Europe of rare disease and rare eye disease. So we included the 342 patients with congenital aniridia, ranged 3 days old to 78 years old, with sometimes complex phenotype and complex genotype also. In this cohort of patients, we have, of course, most of them sporadic aniridia. We will see the repartition between family aniridia and sporadic cases. But we have also 27 Vagre syndrome, 4 cases of Gillespie syndrome, microdeletions, and Vagro. We have also syndromic aniridia with 2 diseases like aniridia and Ehlers-Danlos syndrome, aniridia and tyrosinemia, and aniridia and craniostenosis. So the first sign is aniridia limbal insufficiency. Just look at the neovascularization in the limbal area. And this child is really very young, is less than 2 years old. And we can observe this limbal insufficiency very early in infancy. So there is a grading of keratopathy, and you can see just on the line that it appears like a very small and very smooth neovascularization or fibrotic syndromes in the limbus. There is also very severe corneal phenotypes. We have 3 young patients with severe limbal insufficiencies, and you can see 6 years old, 7 years old, and 14 years old, and these microdeletions just show a severe corneal phenotype. Autologous serum could be very useful, and also scleral lens could be useful, and the autologous serum can supply the stem cells, and after treatment there is an improvement, as it should be a severe impairment is going. So when there is improvement, it shows that the autologous serum is useful. The second point is aniridia and cataract, and it could be characterized by UBM also, as you can see on the slide here, or just with photography, anterior photos, and by biomicroscope. And you can see here that the cataract are anterior segment subcapsular for one, and the other is cartwheel cataract, which is characterized. We can see also with Pentacam, we can see the evaluation of the aniridia and the angle also. We can see the cataract, we can see the posterior cataract in this case. We observe also sometimes other features, a very special feature that could be individualized, like posterior lenticularis. And this is very important to know that, because when you perform surgery, if you don't know, you are not aware of that, you can have just a posterior rupture, and you see here the lenticularis, and we can take off this opacification to get a better clear central vision. It could be also this kind of anomalies with lens coloboma, which is a complete and partial hypoplasia of the lens, as you can observe here. And in those cases, glaucoma is sometimes more severe. We have just done a very short study to see the patient with cataract forms, and we see there is 20 patients with anterior subcapsular cataracts, 15 with cartwheel, which is characterized of PAX6 mutation, and 2 patients have both, and 1 patient has one cartwheel and the other anterior subcapsular cataract. So when they are entering the OR, we try to do something nice, and they are going by car. You can see here this child just going by car to the OR. And of course, cataract could be operated sometimes early because they are very severe, but most of the time we need to wait until the cataract is really opaque, and before the cornea is not opaque. I just would like to underline the secondary severe glaucoma following artificial iris implantation we can observe, and as it could be very useful, artificial iris in traumatic and aniridia, it's really not very appreciated for congenital aniridia because of the severe complications we can observe. One complication is it could be very rare but very severe, is anterior segment fibrosis syndrome, and this is a very, very old photo. I'm sorry to present that, but this was a young boy with this complication. And this could be very severe because it could be with retinal detachment. So if we go to the retina, we have also foveal hypoplasia, and you can see the grading done by Irene Gottlob, and we can see also the retinography just to look how it is. But the most important is the observation of the classification of the foveal hypoplasia. Here we can observe in OCT, and we can see that foveal hypoplasia is sometimes more important than the partial aniridia and characteristic from PAX6 mutation. So just look at the distribution of the OCT and the grading of the foveal hypoplasia and the degree of iris hypoplasia, and we can look that there is grade 4, sometimes with iris root or remnants, and partial aniridia. And so the foveal hypoplasia could be very useful for the diagnosis of PAX6 mutation. We have also this distribution of OCT and the grading of the foveal hypoplasia here with PAX6 molecular defect done with Professor Valeix in Necker and Cochin hospitals. And so just look at the distribution, and we have here the results of the molecular spectrum of PAX6 mutation, and we have up to 93% 0.5 with the new results of PAX6 mutation, but we have also different mutations that are not PAX6 related. And so just look this family with a bilateral congenital cataract, or this one with complete aniridia, diagnosed at 2 months, and we can see here the ophthalmia, the leukocoria, foveal hypoplasia. So we have also syndromic aniridia like Gillespie syndrome, Vargen-Vagro, and as I said, we have Ehlers-Danlos, tyrosinemia, and craniostenosis. Gillespie syndrome described in 1965 with partial aniridia and specifically cerebellar ataxia and with cerebellar atrophy occurring around 1 year of age, mental retardation and mutation, recessive and dominant de novo ITPR1. So you can see the aniridia is quite different with remnants of iris on the lens, and we can see the anterior segment, and very regular, so it does not appear like usual congenital aniridia. We have also Vague syndrome, where there is a large deletion, around 11p13, with Wilms tumor, aniridia, of course, but genitourinary anomalies, retardation, mental retardation, and syndactyly sometimes. With Vagro also, when there is also obesity and could be related to exostosis or cranial lichens with different mutation also in globe. So the large deletion in 11p13, and we have also the gene for autism and the gene for obesity that can be enlarged with this deletion. So it could be also very special cases, like this very young child. He had congenital glaucoma at 1 month old, and also with cataract, keratoplasty has been done, and with phacoemulsification, of course, with a very impaired lens, and also amniotic membrane. And this is not a PAX6 mutation, it is CYP1B1. Also, this severe anterior segment dysgenesia with complete aniridia, lens aplasia, as you can see on the slide on the right, and FOXC3 mutation that we had to do also a keratoplasty. So in conclusion, really, there is 93%, similar to other study that with aniridia is PAX6 related. And we have also some unsolved cases of aniridia that are currently under further molecular investigation, and we have secure whole genome platform in France, and which is very useful. Majority of sporadic cases with high prevalence of de novo mutation, and marked allelic heterogeneity in PAX6 with high prevalence of novel variants, expanding the spectrum of PAX6 disease causing mutation. Also, high prevalence of PTC mutation, with a majority of patients are candidate for novel nonsense suppression gene therapy to restore PAX6 protein function. So we have hope for that. Conclusion, new insight in genic therapies. And we have one molecule that could be done in eye drops. We need further clinical study to be developed in aniridia patient with the nonsense PAX6 mutation, with these new eye drops possible at Alren. But we have other molecules that will be also tested, and I hope they will be could be useful in the future. So definitely aniridia is a model of translational research. It constitutes a developmental and genetic model for genic therapy. It constitutes also a model for iPS stem cells. And we must adapt research for the benefit of the patient. Phenotype genotype could help in predicting evolution and in preventing action. So thanks to Aniridia Europe and Generis for the everyday support, and thank you for your attention. 2 points also that I would like to point out is guidelines. Aniridia are, of course, available in France in French, but we are working on new guidelines, of course, with European guidelines, and I hope they will be available quite soon. And also, we have the first therapeutic education program for patients, and this is a help also for the patient. I hope that will be possible in Europe after we develop this first one. And I would like to thank my whole team in Necker Enfants Malades and the molecular genetic team with Professor Valex. And I thank you very much for your attention.